So let's move on to the next session. 1-year-old with persistent coagulopathy. Moderator Dr. Malathi, presenter Dr. Upender, and panelists Dr. Priya Kishnani, Dr. Vishnu Biradar, Dr. Mamta Muranjan.
Pre-lunch session, and the case being a persistent coagulopathy may be little too heavy, but then we'll make it light. We have Priya, and then we have Mamta, and we have Vishnu with us. And though the case is 1-year-old child with persistent coagulopathy, I think we'll just ask Upender to start.
Good afternoon, everybody. This is 1-year-old young boy, resident of Kolkata, referred to us with a acute illness, 24 days history of sickness. Initially started with blood and mucus in stools with fever, lasted for 5 days.
You just stop with this. In IAP, bloody diarrhea with fever, what do we have to think? Dr. Ambedkar is here. What do you want to say? What is the child having? Yeah, and acute colitis, that is all. So why this case in liver meat, starting as diarrhea, fever, blood? So now again we have to think what's the next one, what is happening?
And for the same complaints, child was admitted in Kolkata in a local hospital. And during this admission, during the course in hospital, child developed ascites and pedal edema. And by day 5, the diarrhea and fever has subsided.
So we'll stop with this. Something unusual, we'll ask them before we think. Ascites, pedal edema in a short duration illness. Ascites, pedal edema in such a short duration. It's a GI manifestation presenting with pedal edema and ascites. So what would you think of? You think there's a loss. So when do you get, that means there's some loss of protein. You think it's a protein losing enteropathy? Or is it a nutritional, or is there a liver problem, or what is it? So this is how you're going to think out. There's ascites and pedal edema. Was any medication given, native medicines?
No history of
so
any drug.
So would you like to think of something else?
No, just hypoalbuminemia, as you said.
There is hypoalbuminemia and there is a problem, yes.
And historically, child did not have jaundice or features suggestive of encephalopathy or any bleeding or no oliguria. And in that admission, they have found to have hypoalbuminemia, no proteinuria, coagulopathy, and mild transaminitis. So with this history,
what will you think of before he tells you? Now they are trying to tell you that the low albumin is due to it's not due to the loss, it's due to a liver problem. It is due to a synthetic dysfunction, because coagulopathy, and he's made it red and he's underlined that. So he's trying to give you that fact. It is a dysfunction, synthetic function is being disturbed. Why it came there, we don't know, but there is a coagulopathy, a mild transaminitis, but there's a hypoalbuminemia and no proteinuria, to say that the kidney is not involved. The kidney is not involved, because in acute colitis, you could have a renal manifestation and you could have that. So the kidney is not involved. Would you like to ask anything before we go into that? It is giving you some thing. There's a coagulopathy and this.
What do you mean by coagulopathy? Prolonged PT.
Yes, sir. Deranged INR. Yes. No clinical bleeds.
With the synthetic dysfunction clearly there, you should keep metabolic liver disease high up in the...
Because we are talking about metabolic liver disease, and Priya is there, Mamta is there, metabolic.
I'm so cold.
Dr. Vishnu, what if you have seen a child like this in your practice, what would you think of? See, first we just see ascites. We might not have done the prothrombin time also. See, there's no jaundice. You might not have done a 5-day-old baby and it's just coming as colitis, there's edema. So you just think, oh, the baby is not taking food properly. Is it a nutritional and a low albumin? If you have not done the prothrombin time, then you think, what would you have thought about it?
Is the ascites first? Sorry. Is the ascites first or the pedal edema first?
Ascites was the predominant finding.
Ascites was the
predominant.
predominant. So clearly it is an indication of portal hypertension. Ascites starting first and pedal edema going down. Second thing is coagulopathy with bloody diarrhea. That means that there is a GI bleed. If we keep a bloody diarrhea as a GI bleed, then it's quite narrow down the conditions, like the children with liver failure.
This bleed settle.
Infants with
settle.
Because this is only for 5 days, and after bleed child is not going in encephalopathy. That means there is no upper GI bleed or the massive GI bleed which is causing. It's just the lower GI which is causing a little bit of blood stain stool. So this is a liver failure, infantile liver failure.
Something.
Probably
Priya, you want to say
metabolic,
something?
yes.
It's which came first, whether it was the bloody diarrhea or the coagulopathy, and the bloody diarrhea is a manifestation of it.
Child
So I
was
think
up-
that's what we have to think about.
Child was apparently absolutely well. Before this started to have bloody diarrhea and fever. Then he was admitted, and during the course of admission, child developed ascites, and they have investigated and found to have coagulopathy.
So
And
this
by
triad-
5 days, diarrhea has become
So
passive.
this triad of low albumin and elevation of the transaminases and a prolonged prothrombin time is now leading you to some liver disease which might have been underlying, and we have to now unravel what is happening now to the child. Next.
Yes, and next this was what they have done in local physician. He had done sigmoidoscopy, found some erythema and loss of vascularity in rectosigmoid area, and they had approached it as either dysentery with sepsis and DIC or CMP and IBD.
Would you think that was necessary, a 5-day illness? No. Because, you know, acute self-limiting colitis, try not to put any tubes, even if you have the scope, be careful. Because that child you should not perforate. The mucosa is so friable. You know, you'll just not know where the bend is, and if you just are too interested, that's all. So that was, I would not have encouraged that, and that should not have.
In fact, that could be very life-threatening.
Life-threatening, yes.
So this really should be a take-home message that this is not a test that should be.
Most important is usually we have a cutoff. We don't do any procedures for acute self-limiting for less than 5 days. You would like to come in, Dr. Vishnu? Not at all necessary.
If we forget about this liver meat, but if the child is coming to me, I would also keep a possibility that it could be some immunodeficiency with acquired infections.
Yeah. No,
Means if we don't keep the possibility of the liver disease at this stage. First is the liver disease because ascites started first with coagulopathy.
Dr. Ujjal, would you have done an
Immunodeficiency with
endoscopy,
CMV?
upper GI endoscopy if necessary?
Yeah.
Because if they'd come to you with ascites, hypoalbuminemia, a little blood, would you, that might be okay to say yes, there's portal, but not, that's what we want to say. Don't do colonoscopy, not a sigmoidoscopy, and don't have a differential. Now with CMPA, IBD, dysentery with sepsis and DIC.
Could I just make a comment?
Yes.
If the diarrhea has resolved, why are we harping on the diarrhea?
No, because
I
they did
think
this
it's-
procedure.
Yeah. You know, it was a diarrhea of 5 days, and I believe with the treatment,
should not
it
have
had
been done.
resolved. This kid could have been bottle fed, which is one of the common reasons why a 1-year-old might have had a diarrhea. So I would not focus too much on the diarrhea if it's subsided.
No, the
at this
person
stage.
who's thought about it has thought about a colitis causing loss, hypoalbuminemia, and that is the way they've thought. That is what we're saying, don't go into that line. When there's a coagulopathy, it is a synthetic function. Don't do this. Don't think of a GI cause of loss of albumin, and don't try to go into, otherwise if you close this topic, it will just go as CMPA, IBD, and that's all.
Malthi, this child was in Calcutta, and the physician told me that because of this persistent coagulopathy, they got worried. So they started looking for what is the cause of coagulopathy and hypoalbuminemia. They have not palpated the abdomen. They have not thought about liver disease, but because this red herring of bloody diarrhea, they are chasing this bloody diarrhea as
that's
a
what
cause
they
of
think.
coagulopathy and hypoalbuminemia. And in that process, they did all this investigation.
So that's what we're trying to show you again. Please think about and take the child as a whole, and not only some investigation, one investigation, and take it. I think that's what Dr. Mamta is also saying. Now?
And child has received multiple courses of antibiotics,
Oh my God.
vitamin D, and multiple FFP transfusions. And thereafter, though ascites subsided, in view of persistent coagulopathy, they have referred to us.
So when you have multiple transfusions and still the coagulopathy is persistent, what would you like to think of?
1 year old.
Is there, I don't know how easily available it is, but in this setting of hypoalbuminemia and liver coagulopathy, is a plasma amino acid not done right off? Because when you see a high methionine, it really gives you an early indicator, an early marker of what's going on or the next step. Is that not part of how it's managed here?
Actually, in that place, they were not thinking of.
See, they didn't
chronic
even think
liver
of liver.
disease. Liver
Dr.
problem,
Priya.
they were not thinking. of.
See, now that's what we are trying to give this message. When you have this persistent coagulopathy, please take your eyes on to the liver.
Any rickets? Miss?
No.
Any
it's
signs
an
of
examination? I will
Any,
be showing
any
it.
thoughts?
What was the basis for the FFP
Just
transfusions?
for-
How bad was the coagulopathy and why were they given?
Just for coagulopathy. they
Treating
have
a
given.
number.
What for?
Referred with that
what were
history.
you doing? How are you helping the patient?
No, this
think
child was
that's the
referred.
history.
How did whoever looked after them?
No, they were
That was
concerned
treated
because
as
every
well.
time they did the prothrombin time, it was rising, and they gave, and they wanted to prevent the further bleed. See, for them, the bleed was the most important dominant
Do you have
symptom.
any numbers? Do you have
Yes,
any
we are
numbers on
going
the
to show.
coagulopathy?
Showing.
No, with this, are you going to think about anything, Priya, Mamta, and Vishnu? Because now will be coming closer.
I think this is liver disease.
Liver disease, and then narrow it down. Is it infective? Is it vascular? Is it metabolic?
This is a metabolic liver disease.
Metabolic.
The child is having synthetic function deranged, which are persistent,
Right.
and hypoalbuminemia. So metabolic liver disease.
I think you can just tell the thing. Morning they've already spoken about that. When will you think? I think Dr. Goda said. When will you think of metabolic liver disease in a child? At least the few points you can tell them. When will you think of metabolic liver disease? You've come to one diagnosis: metabolic liver disease.
Yeah, persistent coagulopathy is the one of the good indicator of the metabolic liver disease with CNS signs like hypoglycemia, the other features like hypoglycemia, lactic acidosis, the pH is showing metabolic acidosis.
Mamta, you
with high
would
ion
like
gap.
Mamta, you'd like to comment on when will you suspect metabolic liver disease in a 1-year-old child?
I think first, if there is anything unexplained, if there is a family history, consanguinity, it may add to the scenario. But, if there is multiple organ involvement, so these would be the common situations when we would think of a metabolic liver disease.
Anything else, Priya? Would you like to?
No, I think what the two of them have said, and to me, I mean, this is like a stat diagnosis. There's nothing more to think about in this. It's a take-home message that if you have someone with a history of synthetic liver dysfunction, and with vitamin K, you're giving it, and there's a history of this diarrhea, which is clearly a distractor, but blood in the stools, and the presence of ascites. It's a clear diagnosis. I mean,
In metabolic itself, would you be able to say is it carbohydrate, is it protein, is
this
it
is
lipid?
more, to me, this is more a protein disorder. Just given what you're
Just
seeing
this.
here, you're seeing a mild transaminitis. You're not really seeing a hypoglycemia, and you're seeing a significant involvement of the liver with no hypoglycemia. So you've taken off a whole storage
See,
pool.
this is what we want
Yeah.
you all to think. When you come to
I am
metabolic,
sorry, Dr. Malathi, can I just say, why is this not any other chronic
No,
liver
I just
disease?
want to say,
But because, this goes with a chronic liver disease which has gone into a decompensation phase.
no, what is the other etiology you're thinking about?
Right.
Yeah, that's the message
So
over here.
the first message is that if it was a chronic going into a metabolic into this liver failure, you would expect higher liver enzymes and not just a mild, unless you're saying it's so terminal that you don't have
And
much.
this also,
Or
there's
jaundice,
no
exactly,
jaundice.
that's the key.
The transaminases are mildly elevated, no jaundice. So if we are looking at a
Right.
chronic liver disease which is progressing, one would have expected somewhere in the course that we would
Right.
have had at some point, if it was tested, a high transaminase and jaundice at some point.
I think there are some other things which we are not getting in this history, which would have been helpful. Is their failure to thrive?
No, this we just thought for the PGs
Yeah.
and for the pediatrics, what they should think about rather than, do all the investigations like Dr. Yacha and all of us were saying, like you can't do everything. So if you narrow it down, then probably we can come to some investigation.
I think even neonatal cholestasis, if it was there or not,
No,
that
not
may
No,
help.
no history.
But there's no.
Should we go to the next slide?
Excuse me, ma'am.
Yeah.
Can we have the previous slide, please?
Yeah.
You said metabolic at 1 year hepatic venous outflow occlusion, but carry. Will you think of hepatic venous
Persistent
outflow
coagulopathy. Persistent coagulopathy.
carry going into chronic liver disease? Yeah.
Persistent coagulopathy was, I think, not corrected even with multiple
Yeah.
transfusions.
But
No
yeah,
jaundice.
If it goes into cirrhosis,
No jaundice. nothing.
No jaundice. You've got synthetic
Jaundice may
liver
not be there.
dysfunction in the absence of jaundice.
Very
and
rarely
absence
do we
of-
have Bacchiari presenting with synthetic. Next
Yeah,
slide.
excuse me, ma'am.
I think 3-week history of
One more.
ascites.
He's won something. Yeah.
The coagulopathy which is not getting corrected with normal FFPs, we also think from the point of view of the presence of inhibitor, that is where the mixing studies help.
Yes.
So the possibility of presence of inhibitor which does not allow the coagulopathy to get
Yes.
corrected.
So
So that is a possibility. Because usually in the liver disease we have a factor deficiency which usually should get corrected with FFP.
That hematological thing we should always think about. What excludes that would be the albumin also decreasing and the transaminases elevation. So those are the two things. So you always think of the hematological thing,
there's no
but then no. Can we go to the next slide? So yeah.
So, in short, the issues are ascites, hypoalbuminemia, persistent coagulopathy, no jaundice, previously absolutely healthy child, developmentally normal child, no family history of any SIP death or liver disease.
So
in
this
family.
fifth point, previously healthy 1 year child, that was the thing which said, okay, underlying other liver diseases are not there, and they all said unexpected change, unexpected symptoms were all for more metabolic. Is that the thing why you said? Because previously healthy child. Okay.
Yeah.
So,
Yeah.
so till 6 months child was exclusively breastfed, thereafter given normal diet, weaning was started at 6 months of it. He's been given fructose, but well before, at the age of 6-7 months he has started weaning, including some banana fruits also given.
So you'd all agree it's liver disease and not IBD, not cow's milk protein in allergy. Agreed, or you still think that's the cause? Agreed, okay.
So with this history, our initial impression was liver disease, and on examination, weight was at 3rd centile and length was 25th centile. He had mild pallor, no icterus, no clubbing, no features of rickets, and per abdomen examination has shown liver is 5 centimeters below costal margin, which is firm with sharp margin, and spleen is 3 centimeters, no ascites when he presented to us, and other systemic examinations were normal.
So weight below 3rd centile and hepatosplenomegaly and persistent coagulopathy, mild elevation, and they feel it is metabolic liver disease, and she said it's more like protein. You want to change your diagnosis now after the findings, or you're coming closer and closer to the diagnosis, you think?
There is a spleen palpable,
Yeah.
so one would tend to think of has cirrhosis set in, and now the child is also having portal hypertension.
So no ascites, so that I think there's no HVOTO, there's no hepatic venous outflow obstruction, it is just no veins on the anterobrum wall. Next slide.
So with this impression is chronic liver disease with portal hypertension and presenting in decompensation, and at 1 year of age.
No, do we have any differential for this persistent coagulopathy? Anyone has in the liver disease itself? We know it's a liver disease. Any condition where that word is constantly used when you read persistent coagulopathy, profound coagulopathy.
Exactly. Yeah.
We can give them the prize. Oh yes.
Yeah. Yeah.
Huh? Tyrosinemia.
Tyrosinemia type 1.
So if they're wrong, they will give you. Okay, let's see.
Yeah, let's see.
And
Okay.
these are the basic investigations. Liver functions showing bilirubin was normal, multiple records we had, and AST is between 3 to 4 times raised, and he has persistent hypoalbuminemia, and INR is persistently deranged between around 5 and 6. And hemogram has shown normocytic normochromic anemia with thrombocytopenia, and blood cultures were sterile. Ultrasound has shown hepatosplenomegaly along with nephromegaly. And
Would anyone like to comment on that? I think the one who's going to get his DM gastro. Otherwise he'll go to sleep. Now you can answer. Just tell us. Anything there? Anything different you're getting? What? Ultrasound is showing a renal involvement, and you have an AST elevation. ALT is not much high elevation. So whenever you have AST elevation, it could be either mitochondria in the hepatocyte, it could be from the kidney, it could be from the RBC, and that is why ALT is more significant than the AST in liver. So you just see that, see the thing, ALT is just 50, 35 and 25. And the AST is high, indicating that it may not be from the liver. Next slide. Albumin is low. Next slide.
And
you want, what do you want?
Yes, the AFP.
I will be showing.
Okay,
Then
we'll go
upper GI
fast with
endoscopy has
this.
shown no varices. Urine for NGRS was negative. Eye examination was normal. ABG, lactate, and multiple blood sugars were normal. And yes, blood sugars were normal. And final investigations, alpha fetoprotein was very high, beyond our lab cutoff value. and urine GCMS has shown elevated succinylacetone. It's 40 times than
I think
reference
Priya
normal.
wanted methionine even at the first test, but we will not be able to do it. But at least you're all thought about that. Whenever you have this persistent coagulopathy with albumin low, think of tyrosinemia, and that's why you hit the thing. You asked for alpha fetoprotein, and he's done the elevated succinyl. How specific would you think, Mamta? You think 100% you can diagnose only with these two, alpha fetoprotein and succinylacetone, because doing this may not be possible for everyone.
I think
Even
urine
succinylacetone
is quite specific and diagnostic of tyrosinemia type 1. So there's no doubt about that.
But do we get false positive anytime or false negative?
False negative.
You can have a normal succinylacetone in certain settings. I think what was unusual in your case was the absence of rickets in a 1-year-old, where you've already got a set-in of ascites and prolonged PT. To not have any signs of rickets is a little atypical in this situation. That was the only thing that was kind of misleading in classic tyrosinemia.
Any other slide you've got?
No.
Would that be also present in advanced liver disease?
Tyrosine?
Yeah.
No, it's the methionine which is the marker. Tyrosine is not always increased in advanced liver disease. Oh, absolutely, yes.
It's not about putting NTBC and leaving it.
Yeah,
Diet
there
is very, very
is definite formulas like the tyrose-free formulas and
Those formulas
restriction.
again are not available in our country. So finally, it's the answer is going to be still
liver transplant. Yeah. It really again depends on the lab which is doing it. So you can either do it as plasma succinylacetone or urine succinylacetone. There's a debate, but it looks like, at least in our lab experience, plasma succinylacetone may be increased in the face of a normal urine succinylacetone. So if you have a very high index of suspicion, the absence of urinal succinylacetone does not exclude tyrosinemia type 1. I think that's an important take-home message.
Mamta, tell me.
That succinylacetone in urine is a highly labile compound. So you
Exactly.
have to collect the urine and transport and store it and transport it correctly on ice ideally, and to reach the lab, without undue delay. So that might be one factor which can avoid false negative. And then of course you would also look at the plasma tyrosine level. So if you have a high tyrosine in this kind of a setting, and yet the succinylacetone is not in the diagnostic range. And again, for a plasma tyrosine, I would not do a blood spot. I would do a plasma by HPLC or amino acid analyzer.
Yes.
I was just asking the interpretation of succinylacetone in urine. Should it be done along with comparison with the urinary creatinine, or should it be just mentioned as
all these need to be done with correction for the creatinine. That is another critical thing. So that's why the lab that's doing it and how the data is being interpreted is really critical.
And you can get the metabolites of the tyrosine metabolites also present in the urine.
Oh yes,
yeah.
yes.
GCMS.
I think
So
we just
organic
showed one
acids.
slide to say that the variation of alpha fetoprotein is so high. So even in normal, so that was a slide. I think we'll be showing it to you online. And so the message is, that slide will come. It's gone. Okay, I think they've time up.
Oh, by a few
Okay.
months.
So it's time for lunch. So thank you, and thank my panel for that wonderful discussion. Thank you, Dr. Upender. Yes.